from across the pond
Yes.
and speak to a topic that's important to all of us, endometriosis and the diagnosis of endometriosis. I think many of you know I'm a bit obsessed with the topic and really quite interested in moving the needle forward for patients with endometriosis or in the investigative process of endometriosis. And so hopefully this talk will shed light on some of the advancements in this space. I do want to acknowledge that, I usually speak to medical audiences in lectures, but every day I talk to patients. And so I'm going to do my best to have a more of a patient lens in terms of the applicability of some of the concepts here. But I do want you to think of questions throughout the talk and write them down. I don't know if there's a Q&A box that you can start to put things into already, but if there is, put them down there. And there can be a little bit more of a not medical advice per se, but tips and tricks on how to navigate the system and to be able to achieve optimal care wherever you are. All right, without further ado, I will share my PowerPoint presentation. Teo, if you can just confirm again that you can see that.
Yes, I can see that.
Wonderful. All righty, so we're going to focus on endometriosis and ultrasound, taking this disease from invisible to visible. Some of you are already aware of where I come from. I'm from Canada. I was born and raised in a suburb of Toronto called Mississauga. I now work in a city called Hamilton, which is just a stone's throw away from Mississauga and Toronto. And here I function as a gynecologic surgeon, really almost exclusively focused on endometriosis, as well as a sonologist. So I scan all of my own patients, and now I also scan most of the patients for the community of Hamilton and the broader region, including Toronto and many faraway cities. As fortunately, there is a significant increase in the awareness of advanced imaging. I also have an affiliation with the University of Adelaide, where I work very closely with the team there on the Image Endo project, which is focused on a number of things, but mainly on artificial intelligence in imaging for endometriosis to advance it in that regard as well. Very important for people to know that I have different relationships with commercial interests. And I would just want to say, because this is a talk specifically delivered to patients, you're going to see some pharmaceutical companies here, some ultrasound companies here. And what's really important for you to know is I don't talk on things that they ask me to talk on. I talk on things that I want to talk about, and I push forward the agenda of importance of diagnosis and validation and using imaging to enhance clinical decision making. And so I have never delivered a talk on any specific medication to encourage that. I've never delivered a talk on using any specific ultrasound machine. I've never delivered a talk on a surgical device or a surgical approach from a company. And so I'm using my platform in a way to enhance knowledge amongst healthcare providers and patients alike through whatever means possible, because that's really important, is that we get information out there. And also, many of you know that I have a relatively decent-sized social media presence. And so here are my handles, which some of you are already following along. I do include my email address here. I would request that this is reserved for professional collaborations or opportunities rather than any specific patient questions. I do my best to maintain that relationship in the clinical space and not through email or through social media. To start off, my philosophy and approach is going to be outlined, and this will set the stage for how imaging, in particular, how ultrasound is integrated into that approach. The foundation of any kind of medicine, any kind of clinical journey is on the diagnosis, is the concept of yes, no. Is there a disease present? And so that's where things always start. And almost always, along with that, we have the important concept of validation. I don't have to say this to many of you. The diagnostic delay, the journey of a patient with endometriosis is far too long. And through that process, there is an unfortunate amount of invalidation, dismissal, years of poor clinical and surgical treatments. And so a correct diagnosis can really validate people. We want to not only know whether the disease is there or not, we want to know what is happening in the space of the symptoms, generally, the pelvis or the abdomen. And so this concept of creating a true narrative of the events of the pelvis is really important to me. And I'll talk a little bit forward through this concept as the slides progress. Then, of course, once we have a visual sense of what's going on from a yes/no and a severity standpoint, we want to contextualize this with the patient, with their life course. So how old are they? Do they want a pregnancy? Do they not want a pregnancy? Have they had a pregnancy? Do they have embryos frozen? There's a bunch of sort of fertility-based life course concepts. And now we're even getting into some more refined life course concepts like adolescence and postmenopausal women as well. We want to know about the goals of care. What is the focus of this person that we are working with? And we want to know what other diseases or comorbidities, as we say in medicine, this person has. Because unfortunately, endometriosis is often the tip of the iceberg, and there are many comorbidities that can occur with endometriosis. And if we want to optimize the patient's care, their journey, their outcomes, we must look at them as a whole. Then, once we have this much more comprehensive visual and understanding of the patient, this is when we discuss and deliver options. And my approach is to give patients time to digest, reflect, and research these options themselves so that it can align with their goals. Finally, when we are talking about different treatment options, patients should have autonomy in that process, meaning they should get to decide what they would like to do. And so we would provide an informed consent process. And in particular, that's often associated to surgery, surgical planning. And surgery is not surgery is not surgery. There's often a lot of nuance and decision-making in what is done and how much is done and what is taken out and what is left behind. So we want the patient to be fully aware so that they can consent to the surgery, knowing what's going to happen when they go into surgery. So that way it aligns with what we tell them when they wake up. So as I said, endometriosis, unveiling it is much more important than yes and no. It's about looking at the severity. What organs are impacted? Are there adhesions? Is there fertility considerations here? We, of course, want to rule out dangerous problems. And I want you to remember the term danger because this is a very important concept in the space of pain neuroscience. We want to rule in other comorbidities or rule out other comorbidities. And we want and potentially can track progress. We are at the first moment in, I think, all of history that we can potentially watch how endometriosis may change with time in patients who are not selecting treatment options, who are not or who are on treatment options. We may have an ability to understand the concepts of recurrence a bit better because we have a non-surgical visual method of observing this disease. So it may feel like the talk has started, and it certainly has, but the structure of the talk, once that foundation is laid, is to go through some of the different diagnostic tests and approaches. So I want to touch upon surgery and histology, and then focus on imaging, break down the diagnosis, as it is much more than yes, no. Diagnostic tests don't just have to be a blood test or an imaging test. Diagnostic tests could be a questionnaire that you fill out in a waiting room, or questions that the doctor asks you. Could be a physical examination. That's a form of a diagnostic test. Certainly radiologic tests such as ultrasound and MRI, classic diagnostic tests. Historically, surgery was the diagnostic test for endometriosis, and you'll come to learn about why that is quite wrong. Histology also known as pathology, is the microscopic assessment of tissue that's removed from the body to assess for the cells that are present. And the final pillar of diagnosing endometriosis or many other diseases are things like blood tests, urine tests, saliva tests, biomarker tests that don't necessarily directly indicate the disease, but may indirectly indicate the disease. I'm going to be focusing on mostly surgery and ultrasound. So as you know, surgery was historically the only way that this disease could be recognized. Before imaging tests, nobody could for sure say whether somebody had it or didn't have it based on their symptoms. And there were no blood tests that were able to diagnose it. Imaging for all of us has been part of our life. But for some, it may not have been such a prevalent part of life in their early life because imaging has only been around for a short amount of time in human history. So when we look at surgery as a diagnostic test, there are a lot of publications on it, and many people, especially people who are primarily surgeons, focus on surgery as the diagnostic test, the only way to diagnose it. But I want to highlight that the literature has shown a lot of flaws with diagnosing endometriosis through imaging. And I have two pictures on the right of screen, which, in my opinion, are the exact example to depict how bad surgery is as a diagnostic test. So what we're seeing on the top right of screen is the sigmoid colon. And the yellow are fat pads on the sigmoid colon called epiploica. And just below the yellow fat pads is the actual bowel wall, just around there. Hopefully you can see my cursor. That's the bowel wall. These are the epiploica fat pads. And surgically, there's this area here that has a little bit of a suspicion. I think many of you probably have seen surgical pictures one way or another and know that endometriosis can sometimes look blue-black or red. And so we have this area just here that's got a bit of a gray blueness to it. And so that's a bit suspicious. But what you can't see in this surgical view is the very large, deep endometriosis nodule that is within the muscle layer of the rectum. Here's this exact same specimen after it's been removed from the body. And as I peel these little fat pads off of the bowel, you can start to see a lot more of that classic brown blue endometriosis tissue popping through the surface. But if we look at that picture on ultrasound, this was very clear to us, very, very clear. We knew that there was a nodule in the rectum in this region, and that's why we interrogated this area very intensely at the time of surgery. We visualized it, we felt it by squeezing it to see if there was any hardness here, and there indeed was. And so that's why we committed to removing this person's segment of bowel. If you think about this as a diagnostic test, this is a very bad diagnostic test because we literally have to take somebody's bowel out to then look at it by opening it up here or send it to the pathologist to evaluate under a microscope. Nobody's going to commit to taking out a segment of bowel for a diagnosis, unless we're talking about something that maybe is cancerous and there's, a lot more on the line in terms of imminent life and death. This is not a small decision, but we knew that there was endometriosis here from the imaging, and so we, of course, committed to the segmental bowel resection. So let's talk about a few other reasons why surgery is a bad diagnostic test. Well, if you think of surgery as a diagnostic test, many people, maybe some of you, have gone into surgery hoping that the disease would be identified first and then surgically treated. And so diagnostic surgery is not really always truly diagnostic surgery. It's intended to be therapeutic surgery as well. And so if you combine these two things, and surgery is technically the only of the diagnostic tests that can really combine diagnosis and therapy in one, well, there's a lot of limitations from the therapeutic standpoint. So for example, this is a surgical picture of an obliterated pouch of Douglas or cul-de-sac, and we have significant adhesions. This is the uterus on the top of the screen. This is bowel, this is the right ovary, and this is the left ovary. And this space is completely filled with adhesions. This is essentially a disaster scenario to accidentally encounter, and most gynecologists would abandon this. So they would put the scope in, see that the disease is there and very bad. They would close the patient up and then consider another surgery. And that other surgery could be better planned because you know how severe it is. But keep in mind that we still cannot see under the surface here. We know the surface is bad. We cannot see under the surface. So is there a bowel endometriosis nodule here? Who knows? Here's another scenario, also very bad. We have the left ovary here pulled under. You can see a bit of endometriosis here. This is the bowel, which is adhesed to the back of the uterus. And there's endometriosis in other spots all over the fallopian tubes and ovaries. And so sometimes what doctors say is they go in for the diagnostic lab, they get the diagnosis, so check mark, it's there, but then they say, oh, this disease is too severe. We can't treat this. You're going to have a bowel leak. You're going to have an injury to your ovaries. You're going to have an injury to your ureter. So therefore, let's put you on long-term medications. And often these are the GnRH agonist or antagonist family that we know have some issues with long-term use. If they're not managed correctly. So this happens all the time. We have scenarios like this, where this is the pelvic sidewall in a patient who had a previous hysterectomy and one ovary removed, the right ovary. This is the right ureter. And we have endometriosis actually impacting on the ureter. So many gynecologists are unfamiliar with the ureter because it is kind of a non-gynecologic organ. It's a urologic organ. And our surgical training is not quite comprehensive enough to be strong in urology type surgeries in our core training. And this is quite true across the world. However, most gynecologists who do endometriosis surgery have fellowship training afterwards and are comfortable with the ureter. But if you're not one of those comfortable surgeons, you might do a bit of an incomplete surgery, which we call a partial operative laparoscopy or incomplete surgery. I did what I could, and I didn't do any more to protect you, is what we often hear. You have the surgeon who actually can do it all. And some of these are the MIGS surgeons, the minimally invasive gynecologic surgeons. So they go in and they do everything. It's kind of like a carte blanche consent form. So the patient is told, we're going to go in, we're going to see what we see, and we may do this, and we may do this, and we may do this, but we don't really know exactly what we're going to do. We don't know how long it's going to take. We don't know exactly what the risks are because we don't know what it's going to do. To me, this is a very problematic scenario because patients don't actually get to really be engaged in the decision-making process. And so this is a few and far between type surgeon that can diagnose and treat all endometriosis at the same time because they're really experts in the surgical space and have a strong surgical diagnostic accuracy. But this is a bad scenario in general. And then there's the scenario of no endometriosis as well, which sometimes can be valuable, but endometriosis can be very difficult to diagnose laparoscopically as well. So this is the pouch Douglas cul-de-sac in a patient. The uterus is up here. And we have these very small little spots here. These spots are representative of endometriosis. But unfortunately, some gynecologists may not know that. They may not think that that's endometriosis because they're not fully trained in endometriosis. They may think that it's some sort of a post-operative adhesion from a previous surgery or abnormality of the peritoneum. So diagnostic laparoscopy has flaws as well because people might say it's normal, but it actually might not be normal. So moving on from surgery to the imaging, how does imaging play a role and how does it enhance diagnosis and how does it enhance surgery? So let's just come back to the philosophy. We diagnose it in many cases. We can validate our patients. We can get a true map of what's happening in the pelvis, including looking at the specific organs. We can then, of course, contextualize. We can discuss informed consent. And from a surgical standpoint, the mapping of the disease locations to all of the organs affected in the pelvis allows for the patient to decide what to do. I have quite a number of patients who have bowel endometriosis who are either not so symptomatic in their GI system or are managing their GI symptoms, or maybe are not, but they are really quite unwilling or scared of having a bowel surgery on endometriosis because even though in our hands the risk is low for something bad to happen, the risk is higher than an endometriosis surgery that doesn't involve the bowel. And so we give our patients the autonomy to choose what they want. Coming to the concept of the mapping of the disease and the concept of danger that I highlighted before, I want you to think a little bit about the pain cycle. So patients with endometriosis have pain. And when patients have pain, there is a response in the body, and this is a legitimate response. Pain is always real. The brain goes into a mode where it's trying to protect us from the pain. That's why we get flags. That's why we experience it, so we can raise attention so that somebody can help us with it. When we have an imaging diagnosis, we can get the diagnosis and the severity sorted. And in some cases, when we diagnose endometriosis, which is a non-cancer disease, we can allow for people to know what's happening in their pelvis so that they have less fear about what's happening. There may still be fear because endometriosis is a bad disease and it can impact negatively on quality of life and fertility. So there may still be fear, but we take away the uncertainty. We take away the anxiety around we don't know what's happening in the pelvis. And this applies to both scenarios of severe disease as well as not severe disease. In cases of severe disease, we may also encounter things like obstruction of the bowel or ureter obstruction leading to the kidney slowly dying. And so these are scenarios where fear should be a bit more present, and we should address these surgically much more quickly. But in patients who have relatively normal scans with no evidence of deep endometriosis or adhesions from endometriosis, and the ovaries are normal with follicles and mobility, the fallopian tubes are normal, this should overall be a reassuring finding for people to allow them to understand that technically nothing dangerous is happening in the pelvis. And this comes back to the pain concept that not all pain is danger. Always pain is real, but not all pain is danger. And many patients who I have talked to in the space of endometriosis who have achieved a very strong quality of life, who have achieved an ability to live despite having endometriosis, have mastered this concept of knowing their body, knowing when the pain is there, recognizing it, but reminding the patient, the person, that nothing dangerous is happening. So ultrasound has a really strong power of us being able to do that. But what do we look at on the ultrasound? Many of you have had an ultrasound before, and many of you have had probably basic pelvic ultrasounds. Maybe some of you have had advanced pelvic ultrasounds. I want you to see that we look at on the advanced pelvic ultrasound for endometriosis all of these structures. We're looking not just at the uterus and the ovaries, and we are looking at those structures from an adenomyosis and an ovarian cyst perspective, adhesion perspective. We'll look at the bowel, the ligaments, which are the two most common sites of deep endometriosis. We look at the perimetrium, which is where the ureter lives. And so we look at the ureter through the perimetrium. We look at the bladder for bladder endometriosis and the peritoneum overlying the bladder. Peritoneum is the lining of the whole pelvic content. We look at the vagina, and we look at the peritoneum everywhere, including the anterior compartment where the bladder lives and the posterior compartment, which is where the bowel lives behind the uterus. We look for adhesions, which can be obliteration of the pouch of Douglas or cul-de-sac. And we can also understand tenderness with the probe because it pushes on muscles and it pushes on structures. And when those structures are pushed on, tenderness may be elicited to give us, again, that context and the comorbidities, particularly as many patients with endometriosis have what we call myofascial pain, which is muscle fascia pain. And we have a lot of evidence to support this approach through the IDEA group, and the IDEA group is continuously working together to publish literature demonstrating accuracy of this advanced pelvic ultrasound technique for particularly deep endometriosis, as it's highlighted in the name, but ovarian endometriosis as well. And now we are working more on superficial endometriosis, which I'll show you a little bit of. But just to compare, this is truly what most people in the world are getting assessed when they have an ultrasound. So many people ask me, how is your ultrasound different? And so I tell them, well, your previous ultrasounds, the sonographer or a gynecologist, they only looked at your uterus and their ovaries, most likely. And those structures generally don't contain endometriosis, except for the endometrioma scenario, the ovarian cyst scenario. And so if you're not looking for those other structures, you're not going to find endometriosis and you're not going to find adhesions. So I am often confused by the basic ultrasound. That's part of the reason why I have done all the training I've done and become the gynecological ultrasound person I've become, because this is the type of report that we often get in gynecology. Women and those assigned female at birth who undergo gynae ultrasounds, these people have been sorely compromised by an inadequate ultrasound and a trust of this inadequate ultrasound for accuracy. And so this is an unfortunate scenario that we need to move beyond. I don't think any patient really technically deserves a basic pelvic ultrasound unless really it truly is a completely uterine pathology or an ovarian pathology. Even then, looking at these other structures becomes really important for surgical and clinical decision making. And besides the difference between the basic and the advanced ultrasound, there's also a necessity, a need to look at who is doing the scan and how much experience do they have, who is reporting the scan, and how much experience do they have. This can apply to ultrasound or other imaging tests. Technically, you can also apply this concept to even something like surgery. Who's looking in my pelvis? How much experience do they have looking in people's pelvises for endometriosis? And so it shouldn't be surprising that those who have less experience have less accuracy in endometriosis identification through any diagnostic test. So expertise matters. One of the things that's really important in the space of imaging and ultrasound in particular is that a normal scan does not mean the patient is normal. So the first thing that needs to be questioned is, was this an advanced scan or was it a basic scan? If it's a basic scan, then really, truly, you cannot trust this normal scan result. As far as you could throw it, it's very useless, in my opinion. If it's an advanced pelvic ultrasound, then a normal scan should be somewhat trustworthy regarding the ruling out of deep and ovarian endometriosis and adhesions from endometriosis. But we know that we cannot rule out superficial endometriosis on ultrasound at this point in time. So we always say to our patients, a normal scan does not mean you're normal. Number one, a normal scan does not mean that there's not superficial endometriosis there. But as previously noted, it can provide a lot of reassurance that the overall pelvic architecture, the connections between the uterus and the bowel and the ovaries and the uterus, these are not distorted. They're not affected by a severe form of endometriosis. And so, not to say that superficial endometriosis is something we can poo-poo or ignore, but it's certainly not the same level of complexity and significance in terms of surgical implication as superficial endometriosis. So it is overall a more reassuring state to have a normal scan, but with the caveat we can't rule out superficial endometriosis. So that's why in my center, whenever we have a normal scan, we first tell the patient we can't rule it out. We can't rule out superficial endometriosis and that the pain is real. But we have to also tell the people who are receiving those reports, which could include a GP, a family doctor, a nurse practitioner, a gynecologist in the community. We must tell them that they should not invalidate or dismiss their patients because the scan is normal. They are not really normal in that they are experiencing pain. This is an abnormal experience, but it is not. It's just that we haven't seen the pathology on the scan today. So just going back through that approach, the key beyond the diagnosis, beyond the present or absent, which is way too basic, is we need to understand the extent and the comorbidity. So this is where my nuanced approach comes in, and I hope my nuanced approach can be used all over the world to help patients get a better understanding of what's happening in their body and to avoid any type of surgical surprise. So just to show you some ultrasound pictures, because there's no such thing as an ultrasound talk without some ultrasound pictures, I'm going to show you some back-to-back surgical and ultrasound pictures so that way you can get some awareness of what it looks like on ultrasound. So that way you know that, what we're seeing is legitimate. There are visual cues there. This is a surgical picture of a patient with superficial endometriosis. There's endometriosis here, 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 here. You can see that they're all different colors actually, and that's quite classic for endometriosis in the pelvis, different colors and all the same disease. Well, maybe the same disease. And so ultrasound, to orient you a little bit, this is a transvaginal ultrasound probe. The probe touches the vagina because, of course, it's in the vagina when we're scanning people. And this black stuff here is fluid that's in the patient's pelvis. Fluid in the pelvis is a very normal thing, and most women and those assigned female at birth with gynecologic organs have fluid in the pelvis when we scan them. And the white stuff here is the uterosacral ligament. And what we're seeing on the uterosacral ligament is this little flappy white structure here. It's jiggling as we apply pressure with the probe. So there's a lot of dynamic movements with the probe in and out to elicit that jiggling. That is superficial endometriosis. This is a different patient than the one that you just saw the surgical picture of, and that's this patient's superficial endometriosis. Superficial endometriosis may be even more subtle. There's these two little white spots that we're seeing here, and it's enhanced by the presence of, again, fluid. That's this black content right here. Superficial endometriosis is usually millimeters in size, very, very small. I often say it looks like a mole or a skin tag, and it just simply lines the surface of the peritoneum, which we're seeing here, here, and here. And so this endometriosis here, these two spots are represented in these two areas here. Again, with the movement of the probe, which is in the vagina, that's the vagina here. This is the peritoneum, which is the lining of the whole abdomen contents. We have this little white round structure that's jiggling on the peritoneum. And this is a little bleb of endometriosis that's depicted right here on the surgical view. Only able to really see this truly if there's fluid. So if there's no fluid in the pelvis in a scan, it's much more difficult for us to see superficial endometriosis. And then this patient here has a different form of superficial endometriosis called a peritoneal pocket. This is when endometriosis implants on the peritoneum, and due to its inflammation, it kind of eats a little hole through the peritoneum. It's kind of like a moth-like behavior, where a little hole is created, and the fluid that's in the pelvis enters into that hole, creating a little pocket. And so what we have here to the right of screen is this little pocket collection of fluid. And between these two bands here, you can see an opening at some points. That's the opening to that pocket. This is another clear depiction of superficial endometriosis. And surgically, this is what that looks like. You see the defect here, like a moth has eaten a hole. And on the other side of that hole is more peritoneum now, and the fluid settles into that space there. Here's another very subtle depiction of superficial endometriosis. This is another transvaginal ultrasound, and this is a cervix here that the probe is touching. The cervix is accessible in the vagina. That's why people can get pap smears and biopsies and IUDs and deliver a baby. The cervix continues into the vagina. And so this probe here is identifying a small deposit of superficial endometriosis as per this small white dot here. That's jiggling a little bit in the fluid. This patient here was a very young patient and was already having very severe pain. And so by telling her that she has the endometriosis, we have a validation, we have a diagnosis, and we have a treatment plan in place for her. But it's also very important that we have the concept of safety, again, reminding her that her uterus, her ovaries, her tubes, her bowel, her bladder, her ligaments, all of these structures are anatomically normal. They're not stuck to each other, even though it may not feel that way and things feel like there's a bomb gone off inside. They are anatomically normal, and that should be reassuring to the patient overall. It should also be optimistic for future fertility if that's an important factor for somebody's life. Some more advanced forms of the disease are seen here. This is a patient who has an obliterated cul-de-sac, again, severe adhesion between the rectum and the back of the uterus. What you can see is a little bit of endometriosis at the surface here, but you can't see what's beyond the surface. And this is what's beyond the surface. Here we have a very, very classic bowel endometriosis nodule. This bowel endometriosis nodule is dark in color, it's gray-black, and you can compare this area here to the bowel above, which is here. This part of the bowel is normal, and this part of the bowel is normal. So this bowel nodule extends from about here to about here. And so you just going back to that picture, can't see that on the surgery views. You can see that on the ultrasound views. And so if the surgeon doesn't know it's there, I can guarantee you that they're not going to be cutting into the bowel to excise that nodule. And at the end of the surgery, that nodule will still be there. And possibly, very likely, which is what's happened a lot in the past, patients have been told all of your endometriosis is out of the body. There's nothing left. We've excised it all. And that's incorrect. This is a different way that endometriosis looks on the bowel. This is a smaller type of a nodule, but again, it shares the same kind of consistency in the view. It's same dark gray in color, and you can connect the normal part of the bowel. So just looking at the top right panel here, we have a normal black line here, we have a normal black line here, and then all of a sudden we have this triangular shaped abnormal black area, and that's the endometriosis. And that's this patient here. So when we start the surgery, we can see there's this very large ball-like structure. This is a very large left ovarian endometrioma, and the right ovary is right here with the tube right here. Both of the ovaries are completely stuck to each other, left and right, and the bowel is pulled up and under right here. So because we knew that there was an endometriosis nodule there, that's why we specifically went looking for it at the beginning of the surgery to see where is it stuck. We want to make sure we keep an eye on it because we're going to be going back after it later in the surgery. But you can appreciate that, this left ovarian endometrioma is quite large. It's like probably about 10, 12 centimeters, and it's occluding the view of that until we actually lift underneath and we look in that area. And that's when we can see that there's an adhesion there. But again, remember that a surgeon cannot see that endometriosis with their eyes. They can see the adhesion, sure, that's there, but not the endo itself. A little bit less complex type disease, which is uterosacral ligament. This is one of my biggest obsessions because it is the most common site for deep endometriosis, and I believe it holds the key to almost all endometriosis diagnostics is understanding uterosacral ligaments. These are ligaments that connect the uterus, hence the name utero, to the sacrum, sacral, uterosacral ligaments. They're very important for concepts like prolapse, and that's where the nerves to the pelvis travel for sexual function, for bowel and bladder function. And so it's not surprising that lots of patients with uterosacral ligament endometriosis do have bowel, bladder, sexual dysfunction. So this is a deep endometriosis nodule on the right side here, and some more superficial type endometriosis on the left uterosacral ligament. And that's what it looks like on the ultrasound there. Again, same concept, dark black, somewhat regular, somewhat irregular outer borders, classic. And here's a video showing a uterosacral ligament endometriosis deposit as well. So just to pause the clip here, here's the nodule of endometriosis within that uterosacral ligament, that long white stripy band there. This is a very small nodule. It's only a few millimeters in size. So I often remind my patients when we see this type of subtle stuff to like kind of create that with your hands, make a centimeter with your hands or use a ruler, and then you can see how small this disease may be, which kind of helps explain why historically it has been relatively poorly diagnosed. But if you know the techniques and you know how to understand what it looks like, you can find it even when it's very small, including superficial endometriosis, which can be smaller than 1 millimeter. This is another uterosacral ligament endometriosis deposit there. When the uterosacral ligaments are affected, we have to assess the ureters because the perimetrium is where the ureters live. And we don't want anybody to lose a kidney to endometriosis or to any disease for that matter, but certainly not for endometriosis. So we always assess the ureters, which is right here. The ureter connects the bladder to the kidneys, and the ureter can be blocked. And if the ureter is blocked, the kidney is technically blocked as well. And that's when we can get hydronephrosis, which is fluid buildup in the kidney, and we can get silent kidney death. To be honest, it's almost never silent fully because most of these patients who have suffered the loss of a kidney have complained to their doctors about pelvic and abdominal pain for a long time, but have just never had the kidneys or the ureters evaluated. And have never had a diagnosis per se of endometriosis. So those people have unfortunately suffered at the poor education and awareness of this disease, which hopefully we can change with time. And so sometimes these patients need a more advanced surgery with a urologist, and that can include what we call a ureteral resection and reimplantation. So this is the ureter that we've cut in half. There's a stent inside the ureter right now, which is going to help us reconnect it to the bladder, and then sew the ureter at this area here to the bladder so that the ureter can redrain without a blockage. I wanted to show you the sliding sign because this is something that some of you may have heard about. This is one of the more early types of ultrasound techniques that's being introduced in different ultrasound clinics around the world. This is a uterus that we're pushing with our hand through the abdominal wall. And so if you have any ultrasounds where the sliding sign is assessed, people will be pushing in your lower abdomen. And what we're watching is the uterus is sliding along the bowel contents here. We can really trust this test if it's done, again, in expert hands, because that's been shown in the evidence to be accurate. So this is a positive sliding sign here, indicating that this is a normal space between the uterus and the rectum. However, this is a negative sliding sign here, where we're applying pressure with the probe, so pushing inwards into the vagina, and that uterus and the rectum are completely stuck to each other. So therefore, this is a negative sliding sign. And we've just added the triangle sign to the mix, which is another type of assessment tool for looking at adhesions between the uterus and the area behind the uterus. And this is applicable to patients who have a retroverted uterus, which is not an abnormal uterus orientation, but it is a common uterus orientation that people have. And we have to apply a specific type of assessment tool to the patients with a retroverted uterus, so that way we get the diagnosis correct. And then finally, just nearing the end here before some questions, we have to make sure that we're looking at the patient again as a human, as a whole. We can't just look at endo. We have to look at other gynecologic diseases such as adenomyosis, polycystic ovarian syndrome, fibroids, polyps. We have to look at ovarian masses. These are the classic kind of anatomical gynecologic diseases, but people may also have things like they could have vulvodynia, they could have discharge. There's other gynecologic things we must pay attention to. We have to pay attention to GI issues because lots of patients have been told they have IBS, or they may be celiac, or they could have Crohn's or colitis. They almost always have bloating. So there's GI aspects to this disease and concurrent diseases. Genitourinary means the urinary tract. People can have painful bladder syndrome. They could have a history of recurrent urinary tract infections. They could have abnormalities with their ureters. We have to pay attention to a patient's neurological and psychological status as well. I had a meeting this morning with one of my clinical psychologists that I work with, and there's a research project ongoing showing that patients with endometriosis have an incredibly high rate of PTSD. And so for sure, the neurologic system, which now we're more specifically calling the pain system, is playing a role in the patient's experience and maybe leading to a more exacerbated endometriosis experience than if the pain system was not turned on. And finally, the musculoskeletal system is really important. As I mentioned earlier, with the probe, we can assess for tenderness in the muscles. We can do that by physical exam as well. And it turns out that lots of patients with endometriosis may have as well history of trauma with sports injuries or vehicle injuries. They may have injuries with low back or their legs. So we must keep those in mind because the pelvis is connected to all those structures. And we don't want to only blame endometriosis, because if we do, then medication surgeries are not going to be enough for sure. And we must integrate things like pelvic floor physiotherapy, osteopathic maneuvers, acupuncture, for example, as some of the more physical techniques. So just to finalize the presentation, some of you may have heard me say before, diagnosis is therapy. Diagnosis is for sure the gatekeeper to therapy. If you don't know what you're treating, you're not going to treat it effectively, and you need to know all of the things that you're treating. And as well, I believe wholeheartedly that diagnosis is therapeutic for people. There's an immense validation that comes with that experience, and through that, people can start to feel better and understand what's happening and sometimes what's not happening in their pelvis. Thank you so much for listening. I look forward to some